The
discussing morbidity case, unusual presentation of acute appendicitis. Karibuni. Okay, so my name is Dr. Damaris Mbalu. I'm a general surgeon. I work in the hospital. Dr. Safwat is the consultant on the case. He will give his comments. And the radiology discussion will be done by Dr. Grace Gatete. So the team that was involved, there was a pediatric surgeon in the management of this patient. We invited a laparoscopic surgeon. Then there was a pediatrician, gastroenterologist, the anesthesiologist, of course, because of surgery, and the radiology team. So we are presenting MW, a 10-year-old, who presented to us on 29th of September last year and was discharged on 15th of October. So he was with us for 16 days. And how he presented to the outpatient clinic is that he came with a history of saying that he was hit by a ball while playing soccer. And that happened 4 days before the day he presented. And he just says that he felt lots of pain that time. Then that evening after he came home, there was one episode of vomiting. And another one was reported the day before he came to the clinic. What they had done before is that the dad had gone to a pharmacy, and the outpatient over the counter, and he had been given Flagyl and promethazine. That didn't help, so he went to the Khan outpatient clinic near him, and what they did is they did a stool microscopy, and it came out normal, and so he was also given Zinat and enterogramina. So when he presented, he was having normal stools, no diarrhea, and he was passing gas. There was a reported fever that morning before he came to this pediatric surgeon patient clinic. He had gone to the pediatrician, and there was a fever of 39, and the medication he was given then was Panadol. So when he presented on exam, he was basically a sick-looking boy, walking while bent sometimes, and on the vitals, the pulse was elevated at 120. By then, the temperature had normalized to 37 because of the Panadol. The other vitals were normal. To just specify, on the abdominal exam, there was moderate abdominal distension. It was tympanic on percussion, and there was some percussion tenderness, but and some increased bowel sounds, but no really rebound tenderness per se. So the working diagnosis then was, query hematoma, but really to rule out bowel perforation, because this boy was the history of trauma and the temperature and the pulse of 120 and just the peritonitis. So the plan was to do the workup now, an erect abdominal X-ray, an ultrasound, and we talked to Dad about an admission, IV fluids, and to just make a diagnosis and monitor, and to do the labs. But Dad was really a little difficult. I remember seeing him in the outpatient casualty, and he's like, I need a diagnosis. I'm a specialist. I don't want my boy to go to the hospital without a diagnosis. We don't want to count goose in the hospital. So, but we still convinced him and talked to him. So we went to the patient to the ultrasound, And basically there were no nodes, no free fluids. Remember, we are trying to just make sure there's no perforation, and but dilated bowel. And we were present, and the patient really tolerated the ultrasound. There was no very, like on the probe, no very severe tenderness. So that sort of made the diagnosis. We are trying to make the diagnosis. So he also went for an erect abdominal X-ray, mild bowel gaseous distension. Radiology will be discussing, but I'm just giving the summary. Multiple air fluid levels, no rectal gas, no much fecal loading, and no free gas, no free peritoneal gas. So query intestinal obstruction. The labs that we did, white count came normal at 7.5, but there was a shift of the neutrophils at 69. Normally it's up to 65. CRP was elevated at 319, and PROCAS was also elevated at 12.3. All the other labs, the UECs came normal. So in summary, we have this 10-year-old abdominal pain, this history of trauma. So we are, looking for, is it a perforation? Does he have a hematoma that is giving us ileus? The workup that we have done is an erect X-ray that is querying query obstruction, but we know it's partial because it's passing gas. He's also passing stool. He has a fever. He had a tachycardia. Ultrasound, no free fluid. So perforation is sort of out now in some way. And so we have a diagnosis of partial bowel obstruction due to the trauma, no hematoma from the ultrasound. So admitted for observation, given antibiotics and Profalgan and an enema. So that's a summary that I've given. For now, what we have done, we taken patient to the ward and admitted. So after admission, he actually improved. Opened bowel, so now obstruction is sort of out. We are improving. Abdomen has become soft. He's on IV fluids. He's eating and tolerating. We don't have a fever. So from the surgical point of view, we have this trauma that gave this ileus or slow bowel is now improved, and we want to discharge the patient. So we are planning that, but there's also the pediatrician on board. So we are observing and making the decision together. So those were the first from 30th to 1st. So on 2nd, patient develops abdominal pain after breakfast, but he has passed stool 2 times, no vomiting. There is distension is decreasing. So the working diagnosis now are, fecal loading, constipation, rather, very fecal loading. So the patient was started on PEG-LEC. Child was also a little hard, a difficult patient in some way, refused the PEG-LEC, the test wasn't the right one. But that day he also passed stool mixed with loose stools. That's now on 3rd. He has some abdominal pain. So the plan then was to give PEG-LEC, and after he finishes, he gets Dufalac and Movicol. Passed stool with PEG-LEC, so now we, complete obstruction is out, and part loss of stool. And there is only complaining of some abdominal pain before, during passing stool. After that, he's fine. So a gastroenterologist was invited on board, and his plan after his review was we continue the PEG-LEC, and he ordered a CT abdomen. So on 5th, no pain, opened bowel, ruling out obstruction. We have some labs back. Amylase and lipase were normal because the other plan was to rule out are we dealing with pancreatitis from the blunt abdominal trauma? CRP has come down to 169 from the 300, but we have an elevated white count of 14,000, and platelets are also going up. So there is a problem because we're already on antibiotic. This patient was already on antibiotics, so something is not adding up in this history. So we're waiting for the CT abdomen. On that day, around 2 p.m., patient's abdomen is more distended, hence he opened the bowels. So CT abdomen, we walked to radiology. We have a discussion on the images. Radiology will be discussing soon in the next slide. But what we have is that we have small bowels filled, filled with fluid. Large bowel has gas. Thickened bowel wall. There's free fluid in the perihepatic region and in the pelvis. So that just CT view, some free fluid on the perihepatic region and the pelvis, but I'm not the expert. Time for the expert to take us through. So we'll go through the radiology discussion and give you a summary, and then we'll keep the questions to the end after the summary. So keep them down.
Good morning, everyone. So I'm going to go ahead with the radiology findings. The biodata that the carrier has given us is MMW, 9 years old male, who came with a clinical summary of blunt trauma between 4 to 10 days. And the investigations carried out, as we have been told, was abdominal X-ray. Ultrasound of the abdomen, which was done on 29 September. Another one was done 5 days later. And also we had a CT abdomen on 5th of October. So we did a supine and also an erect plain abdominal X-ray of the abdomen, where the salient feature was distension of the small bowel. You see those valvular collimentars there. And no evidence of pneumoperitoneum as such. There are air fluid levels, and there's paucity of rectal gas. So the findings on this plain abdominal X-ray were consistent with the intestinal obstruction, and as is the norm, we informed the primary physician at that point. So afterwards, they requested again for an abdominal scan. What we see again is the demonstration of dilated bowel loops. You see those echogenic structures, which is intestinal contents. We did not see any hemoperitoneum or free abdominal fluid, free pleural fluid. The other intact, the solid viscera was intact. This was kind of a forecast. It was a general ultrasound, but also focused just on assessment of trauma. It was like a first. So this again was just to highlight the normal solid organs. That's the spleen. This is the dilated blue bowel. Those are the kidneys here, and then that's the liver, which are all intact. Again, a follow-up abdominal ultrasound demonstrated this distension of the bowel loops, again with the echogenic contents. The peristalsis was reported as non-forward. It was just neither here nor there, but it was still there. So again, at this point, there was no free intraperitoneal fluid. So Again, the report was suggestive of intestinal obstruction. There was no ascites, no nodes, no abdominal mass, probably causing extrinsic compression. Just again, dilated fluid filled bowel loops. We went ahead and a request was made for a CT abdominal and pelvic. That was on 5th October. So the clinical information at that point was hit on the abdomen by a hard ball. He had inflammatory markers at this point. There was abdominal distension. The concern was assessing the pancreas for necrotic areas. Comparison was also made with the previous scans of the ultrasound scans which had been done. So this is a scanogram. We just see again marked distension. I think we can remember the previous one when he came in. This had progressed. And at this point, we see free intra-abdominal fluid, still no pneumoperitoneum visualized at that point. These are quite dilated bowel loops, both large and small. And this is just a coronal post-contrast scan, again, redemonstrating the same. What we could see also, which perhaps was not mentioned in the initial report, was an appendicolis. There was one there. And this is the pre-contrast scan. It was a calcified one. The Hounsfield unit were coming to 362. And around there also there was actually inflammation. That is just looking at it retrospectively, and thick end of the adjacent bowel loops there. So that could have also probably pointed us to consider a possibility of appendicitis. But I think the dilated bowel loops also sometimes brings diagnostic confusion. Yes, this was actually the Hounsfield units were coming to around 403 Hounsfield units. And this is just the periappendiceal area. We see those thickened bowel loops, probably loop of, that was probably the appendix there. We can just adjacent to this appendicle. Probably if I would have brought in a scrolled view, it could have been better appreciated, but it was a big calcified appendicle. Yeah. So the CT scan findings at that time was there was general small and large bowel distension with multiple air fluid levels, but no obvious transition point. There was moderate interperitoneal free fluid. There was no pneumoperitoneum. And then the pancreas was assessed and it was found to be grossly normal. What we have seen now after reassessment of the images and the clinical, the surgical findings, intraop findings, there was an appendicolis with adjacent periappendiceal fat stranding with increased enhancement around there, suggestive of appendicitis. Just a small discussion. Appendiculitis is seen with increased incidence in children with sickle appendix. Overall, they are seen in 10% of patients. Sorry about that. Yeah. So multiple appendicolits and appendicolits larger than 5 millimeters are associated with acute appendicitis. A study by Park et al. Reports the overall sensitivity of CT for diagnosis of acute appendicitis as at, they put it at 96.4. Several randomized trials have shown over the years have shown that sometimes CT misses even the diagnosis of appendix, though it's highly accurate. And then again, Multiple air fluid levels could have led to diagnostic confusion, particularly in this patient. Thank you for your attention. So I'll give it back to Dr.
Okay, so thank you, Dr. Grace. So now the moment of decision making. Of course, she's described what the CT findings were and some wisdom in retrospect. People say that most people are wise in retrospect. So we are already now in hospital day 6. We have a CT scan report of free fluid and worsening symptoms. CRP is still high, or rather the markers are high now. Abdomen distended and tense. So we plan to go to do a diagnostic laparoscopy. So we invited our laparoscopic surgeon. So we went to the OR. By the time that was in the evening. By the time we got our theater space, it was around 9:45 p.m. So on diagnostic laparoscopy, we found yellowish fluid at the Morrison's pouch and the pelvis, thickened distal small bowel that was stuck in the omentum, and it was really friable. On further, just checking in, pus pocket was found retrocecal and found a perforated appendix. So what we did now, because we had all the an opportunity to wash, we could see all spaces, we did a thorough washout. And because it was hard to really access the appendix and do a good job, and with this very friable and stuck bowel, we decided to open. So on open exploration, found a perforated retrocecal appendix with a retrocecal pus, contained pocket, and there was also an appendicolith. Did now the local washout, did retrograde appendectomy. Pus was sent for microscopy culture and sensitivity. We left, drained, and closed in layers. That's not a very good picture, but just to show the bowel that was thickened. But from there, at least you can see through the incision that we made. And the reason why we didn't do a midline incision is because from the laparoscopy, we had seen what was there, and we knew we had done a good washout. So we were confident that we will do a good job with the limited incision. So there's pus through that is coming out through the incision. Our picture on closure, and that is the appendix we got out with the distal end necrotic, and that is the appendicolith. Yes. So patient did well. For the next 4 days was stable. Inflammatory markers were coming down, started on SIPs, drains removed, passing gas. We at some point got mild distension, but he soon improved. He finished his course of antibiotics and was discharged. So to summarize, for those that joined late, or to just because it's been a long presentation, we are presenting a 10-year-old who presented with a history of abdominal trauma, which at this point I would say was a red herring to the primary pathology. So totally diverted the concentration and the thinking, and just gave us a focused, or rather, I would call it now a pinhole thought on the differentials that we are working with. And so I would say in the initial 3 days, we are ruling out a bowel perforation, and we ruled it out. And then in the next 3 days, before we have a true diagnosis, we are wondering why is this patient having bowel obstruction, dilated loops of bowel, and all those air fluid levels, yet he's opening bowels. So the other history that he presented with was fever, abdominal pain, vomiting. Like I said, he initially improved with treatment. He had been on antibiotics, Zinat, metronidazole as an outpatient. Came was given augmentin, amikacin. So that made him improve, I would say, but worsened because now we know the primary pathology had not been dealt with. So required further investigation, the CT that has been discussed, and intraoperatively, we found an retrocecal appendix, and would say did not present to us classically. The trauma just diverted the thinking. It was not diagnosed also on the initial, on 2 ultrasounds and even the CT scan. Spent 6 days in the hospital before surgery. So, and that is sort of like 10 days because he came 5 days later. So 11 days before intervention from the onset of symptoms, and the findings were necrotic appendix. We are presenting this patient because of the long hospital stay, 16 days, the delay in diagnosis, the things to learn from the presentation, from the history, and even from radiological presentation. Just an add-on to the summary, also very difficult patient that I think was very well apprenticed by his dad, and also dad was difficult. We signed consent, he refused, he wanted to go home. It was, a lot of work that we needed to do also. So that is the summary of the patient. But to just summarize, after we made the diagnosis, gave him the right treatment, he did well, finished his course of antibiotics because of the necrotic bowel. He needed to be in the hospital for some time, and no complications. He's come to the outpatient clinic and has done well. So thank you. Questions are welcome. Dr. Safwat will give his comments, and then we'll discuss shortly just a few slides on why this unusual presentation of acute appendicitis. Dr. Safwat?
Hello? Yeah.
Hi, we can hear you.
Yes, good morning. A very nice presentation. It is really a learning experience because usually appendix is a straightforward diagnosis, but when it really takes 3-4 days and go to another hospital and they take a lot of antibiotic and a lot of pain medication, it become also the history become misleading. You treat as blunt trauma, and then you X-ray radiologist saying it is obstruction, but the patient is passing stool. It become a challenge. So it teaches us that always you don't look for the classic and you expect unclassic. And when it is unclassic presentation, usually it is very difficult, and we have to be somewhere between a balance between being so aggressive, but aggressive, you go to open with no diagnosis is also not ethical. In the same time, you need to be careful and monitor and frequent, examination, frequent assessment by ultrasound, and work as a team. I think also, even if in the start, radiologist has missed even to tell us about the ficulus or appendix, but they were very keen on even calling us and saying, look, there is a free fluid, and that is the time we said enough is enough. So I think working as a team and also with the pediatrician, with the gastroenterologist, with the laparoscopic surgeon, with the anesthetist, with the radiologist, is really makes things easier and really protects this patient from getting more worse or even discharging him. If we agreed with the parent, we would have even let this patient go home. He refused surgery. Even after signing the last day, he changed his mind. I almost pleaded, say, please, please allow me to operate, and he would refuse. So anyway, thank the team. And also the most important is, I want to assure you, even after all this pus came out, this wound healed primarily. So congratulations even to our theater team who kept sterilization and who were very ethical that we didn't even get a wound infection. We will be happy to receive any questions, or you continue your presentation, Dr.
Thank you very much, Dr. Safwat. I'll take questions on a presentation, history, anything you want clarification on. If I just make a few slides on the discussion.
You don't want to finish the presentation, then we go to the discussion? Okay.
I can do that. So acute appendicitis, inflammation of the appendix, mainly typically presents with vague periumbilical pain for several hours, which later migrates to the right iliac fossa, lack of appetite, nausea, vomiting. So how classically diseases were to read books would be pain, then vomiting, and then now we have a fever. Looked at this paper 2014 Internal Journal of Emergency Medicine that had prospectively followed 146 patients, and from their summaries that 95% of their patients presented with right iliac fossa pain, 80% with nausea, and vomiting was 73%. Fever was only present in 15%, so not all patients are present with that, and only 31% of the patients gave a typical history. The sensitivity of the ultrasound was 60% with a negative predictive value of 31. So this discussion will not be complete without talking about the Alvarado score for the sake of the learners and for everyone. So the mnemonic is mantras, and I was just trying to score our patients now in retrospect, in wisdom. He had nausea and vomiting, that's one. And I would say the percussion tenderness that was there initially, I don't want to put it around the rebound tenderness though, but he had an elevated temperature of 1, so that's 2. And there was a shift to the left of the neutrophils, because in the initial WBC it was not elevated, though I would say he had been on 2 antibiotics that may have interfered with the presentation. So that comes to 3. But if I add the leukocytosis now that we found 2 days later, to come to around 5. So from our assessment score, it would be probable appendicitis, that is between 4 and 7. Another study to just talk about the CT scan diagnosis. This journal looked at 1670 patients that they studied over 8 years, and that 33 of their patients had a retrocecal appendix, and only 70% of diagnosis was made on CT scan. 33 had appendiculitis, and more than 50% of their patients presented with atypical symptoms. Reminding us of anatomy, so 60, okay. So the origin, or rather where the base of the appendix, it's the joining of the 3 tinea of the cecum. But now the tip is the one that varies in location, and depending on where it is, that is why the symptoms would vary. And most of the, actually 64% of the appendix is retrocecal. The rest are the percentages. The next is pelvic. The, you know, nodes, because in children, one of the differential diagnoses is mesenteric adenitis, even in adults. And when patients get upper respiratory infections, that may give us the primary pathology or may sort of interfere with the diagnosis. It's on average it's 11 centimeters, but it can range from 2 to 30 actually, and the diameter is 7 to 8. So on ultrasound, when it's more than that, there's an issue. Reminding us of McBurney's point, where it is and where we look for the McBurney's sign. There are a couple of signs in appendicitis, the rovings and the sores, depending on the location of the appendix. Also reminding us of the Murphy's triad, the pain, the vomiting, and the temperature that is in the classical presentation. So mainly the reason would be increase in lymphoid tissue in the young. And so when it gets obstructed, it occludes the lumen of the appendix, and that interferes with the drainage and then the inflammation. Also in adults, mostly fecalitis, but fecalitis can also be found in children. Our patient had a fecalitis. We know the pain initially coming to the umbilical region and going to the right side, and this is because of the visceral innervation and somatic. So visceral, because of the afferent fibers of the appendix come from the T10, and T10, we know the umbilicus, that's where the nerves are. So that, but now it comes to the right iliac fossa because of the inflammation, local inflammation of the peritoneum. So that is somatic innervation. So if it's not, diagnosis is not made, then those are the complications that we expect. It can become necrotic, it can rupture, can get septicemia, shock, and even, you know, needing to go to theater many times and death. So I was just looking at the diagnosis of retrocecal appendix in view that it may not present classically in terms of the periumbilical pain and the pain localizing at the right iliac fossa. And there's some data talking about the K sign, and it's given K sign because of where papers have been written from, Kashmir. So it's a Kashmir sign. So mainly it's just tenderness on the posterior abdominal wall. And that means you have to have it in your mind, that is, you're thinking about retrocecal appendix and you're looking for tenderness there. And the region to palpate is superiorly trastib, medially spine, that's on the back. And then the lateral margin is the lateral wall of the posterior abdomen, and lower inferiorly is the iliac crest. And so you're sort of palpating from up down, moving from the lateral going towards the back, and you're looking for a point of tenderness. Papers that were this, okay, not very supported, but there was some case series that had been reported. 4 out of 5 had presented with a positive K sign in a diagnosis of retrocecal appendix. Otherwise, the other symptoms of fever and vomiting will be present, but just the palpation of the abdomen may not be so classical in retrocecal appendicitis, and that may make you to miss. And so maybe if you're thinking retrocecal, looking for tenderness on that region. There's not much support of these papers, so don't crucify me on that. The investigations you want to do, TBC, UECs mainly, and the inflammatory markers, the ultrasound. They say the rate of misdiagnosis on the imaging in early presentation could be 15, but in late even can go up to 50. So the question is there a role of conservative treatment? and doing interval appendectomy. Sort of patient comes, if the appendix is so complicated and it's suppurative, that's why we're having that initial SAPA, suppurative appendicitis. Is there a point of giving them antibiotics and sending them home and waiting for things to cool down and bringing them back for appendectomy? This has been an area of controversy between many surgeons, and I think in the many meetings that a few meetings that I've attended, there is never an agreement on this. So looked at this paper that was looked 18-month period. They looked at 751 patients. 105 of them had suppurative appendicitis that were given antibiotics, and then the plan was to give them 2 months for things to settle down, and then they come back for appendectomy, interval appendectomy. And then the abscess rate was high at 27. That is during when they come back for the appendectomy. And those that needed to come before the 2 months were over were like 11%, and 34% needed to be readmitted. So in other papers, they say your selection of your patients needs to be good if you're thinking of this conservative treatment, reliable patients, not very young, who can present differently. But people have not agreed on this. I don't think they're going to agree on this before, or rather very soon. So the question is, what is this unusual presentation? And the reason my slide is busy on purpose is just to tell you that appendicitis can present as any of those things. And so if you're not keen, you could be treating any of those and missing out on the appendix. Especially in female, we have the ovarian torsion, the ectopic pregnancy, even the ruptured Graafian follicle. And so high index of suspicion. So I'll just summarize back what was unusual in our patient. The red herring history of trauma. I do not know why it came, but that just took the concentration so far away and took time, because I think if this patient had just come with fever, vomiting, and temperature without the trauma, maybe would have thought of appendix sooner than before. But also the fact that they had taken antibiotics, they had gone to many places, and then radiology that was giving us the diagnosis of bowel obstruction, and then we are telling ourselves this patient is passing stool, they're passing gas. Now they're not vomiting. Why are they obstructed? And even for obstructed patients, we don't run to theater. We treat as partial obstruction. But the question is, okay, is the trauma the one giving them the partial obstruction? Sorry, that is not oxygen. Responded to treatment. And the question is now, what is the role of relatives when you're treating patients? Sometimes when you have difficult patients, it sort of can take you away from your clinical decision, because you also have to consider them. So what my conclusion would be, in treatment of appendicitis, high index of suspicion, look for it. Beware of the non-classic presentation, and radiology is also key. But we are grateful that we worked as a team in management of this patient. They did well. They went home, and thank you. Questions now? Of the pathology on, there's a question from the chat, what the necrotic appendicitis with a fecal leaf. To answer the question from the chat.
There is also a question by Dr. Grace Gattetti. Is there a role of explorative laparoscopy with such dilated air fluid levels? It's difficult to answer, because if you have fluid levels, air and fluid levels, it means intestinal obstruction. But if the patient is passing stool and is not vomiting and is feeding, and he said, I am improved, I want to go home, he's 10 years, if he's a baby, you could really do it. And even pain in the right iliac fossa, There's no free fluid. So it was very hard decision, but we were closing very close observation, which really made you to feel the difference in the clinical condition. But occasionally, if there was something else positive other than dilated bowel loops, like immediately that day when they say there's a free fluid and we have seen it in the CT scan, we had to open. But it is difficult at times to just go and explore and come negatively, especially if the parents say, I need a diagnosis, I need to convince me, you show me the x-rays. It was not easy. Any other question or comment? I'm also very grateful to Dr. Gatetti to tell us about retrograde and retrospect about the ficulis, calcified ficulis, and also about the appendix, which is swollen. It is very important that we learn from our mistakes and then maybe or from misdiagnosis, and we put this in our consideration next time.
Dr. Arao, I see your hand is up.
Okay, good morning.
Good morning.
Yes, thank you very much for this presentation. I agree, it was quite a confusing case. I just wanted to ask, this now, I don't understand why the initial clinicians, outpatients, were giving him antibiotics, but isn't that also possibly what delayed the diagnosis? I remember a couple of years ago, there was this debate about whether acute appendicitis should be treated surgically or should antibiotics be instituted, and that way you spare the patient of surgery. So seeing as this patient got both anti-anaerobes and Zinat, isn't it possible this also slowed the course of progression of the symptoms?
Definitely,
Yes.
you know, sorry, go ahead, Doctor.
Okay, yeah, I would say yes, because the antibiotics would interfere with the presentation, the fever, even the peritonitis. And to just add this, like I told you, is a patient that already had gone to the pharmacy, had bought the medication himself, but the patient was not getting better. And on like examining the patient, is like, even me, I know how to palpate that abdomen. Huh? I can palpate it well. I don't think you're doing enough. So that part of the story, the 4 days, I would agree, interfered with the diagnosis. Dr. Safwat, you can add.
Yeah, it's true. Also, remember, he went even to Aga Khan outpatient, and also because of the history, they missed actually the diagnosis also. And when it becomes very old presentation, neglected presentation, you go now to the complication, which nobody can expect it because you are not suspecting. But I agree with you, Dr. because some people, like some talk these days of even the conservative or non-operative management of appendicitis, and they give even antibiotic, but these cases you have to diagnose. You have to know first that you have an appendix, and you do close observation, give antibiotic for a few days, have certain criteria, not ruptured, the lumen is less than 1.1 centimeter, and so on. There's so many things which we don't do it here. If you diagnose, we operate. But of course, you give all this, it reduces the infection. It has even, as you can see, improved the CRP and the procalcitonin. So he was improving. Clinically, he was improving, getting stronger. So it was also part of the misleading. That's why I even tell the doctors in casualty, immediately, if you suspect that this patient have an acute abdomen, don't give analgesia, don't give antibiotic. You are misleading us. Let the surgeon examine and then you give these things, because otherwise you delay the diagnosis, hide it, and so on. But thank you for the comment. Dr. Otieno, please.
Thank you.
Good morning.
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 Thank you for the education. Just wanted to ask, I mean, it's difficult to make a specific diagnosis of appendicitis, but you have dilated loops of bowel. You have fluid levels. You have free fluid in the pelvic cavity. Are we not able to maybe suggest that maybe we have an acute abdomen, and then follow the rest of the protocol? But retrocecal appendicitis, particularly in a child, can be very challenging. Particularly, we've got this history of trauma. So I'm actually looking for, for traumatic lesion, and all through the radiology did not show a traumatic lesion, but it showed dilated loops of bowel. So I'm looking for an explanation, and quite often we would like to correlate this with the clinical picture. How are the bowel sounds at the time?
To start, the bowel sounds was even exaggerated. It was never ileus. Just a small adjustment to the statement that we had the dilated air and fluid levels, dilated loops, but there was no free fluid. We were waiting actually to see free fluid from the day one that we say that this is either blunt trauma or it is hematoma or bleeding. But we only got that explanation the day we operated, that there is a free fluid. That is the day we operated. But you can't only operate alone because of dilated loops and the thickened walls. Because in the same time, dilated loop, you can get a fecal loading, can get ileus, you can get SWAT. You don't need to do laparotomy. So that's why we give the GI doctor gives a Piclic, the pediatrician, and he responded and he improved. So that's why it was difficult. But the day the radiologist told us that there's a free fluid, we went to operate, and it was true that day. We went a turbid fluid, which is like generalized peritonitis. That is the day we irrigated it.
Thank you very much.
Thank you.
Any other question? Okay, Dr. Safat, your closing comments before I give my vote of thanks.
Thank you for all attendees. That's a very good number, and very nice to share our experiences and present to you. And it is a learning experience, and wherever more senior you are, every day you learn, and more you operate it, more you get surprises. So we all learn from each other. We are all to be humble as a surgeon, and we know that we can get difficult cases, but with the help of the others and working as a team, it really solves our problems. And persistency, it make you really help your patient and able to succeed in your work. Thank you very much.
Thank you, Dr. Ari. Thank you everyone again for attending. Thank you to the team that managed this patient, the pediatrician, the gastroenterologist, I see is in attendance, Dr. Lavin, thank you. The radiology team, thank you for your support during management and even for the presentation. Dr. Grace, thank you for coming to support us. And thank you, Dr. Safwat. Thank you, Ken, for making this happen. CPD points, Ken will facilitate on email, right? Or you can email Kenneth Bordeaux. That said, have a wonderful week and God bless. Thank you.
Thank you. Thank you.